ठीक 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 है, लोग कितना झेलते हैं ये भी देखो, ठीक है। सो जस्ट वेरी गुड आफ्टरनून एंड थोड़ा लाइट कर सकते हैं क्या हल्का सा, अगर ये देख विजिबिलिटी में प्रॉब्लम नहीं हो तो हल्की सी, जैसे आई वांट आई थिंक आपका भी इलेक्टेड लेवल बढ़ रहा होगा, टॉक्सिन का टॉपिक है, सो आई वांट यू पीपल टू रिस्पॉन्ड लिटिल बिट बिकॉज monologue is not always good. So another reason I want you to respond, because poisoning is one area where you do not have very hardcore evidence, not a very hardcore RCT. Most of the experiences, I'm okay, audible? Hello? Okay. So most of the experience and most of the presentation are based on case series, personal experiences, physiological and pharmacological findings, and that's the reason many a time if I may say something you may think nahi main to aisa karta hu, so you may be also correct but I am not wrong maybe. So there's like lot of gray area in poisoning. So with this background, few facts about poisoning. It is the leading cause, one of the leading cause, particularly in our setup, particularly in young patients, because of the suicidal tendency and increasing pressure. And most of the time when this patient presents to you, they present to you with very sick condition, maybe deeply comatose, maybe they will be hypotensive, maybe they will be in LV dysfunction, maybe irreversible condition. But despite that they present in extremely sick condition, they need a very organized target resolution, despite you do not know what you are dealing with. What it means? Now suppose a poisoning patient comes to you, he is in shock, he is in coma. It's not like that. The routine, the way you follow ACLS guideline, AHA guideline, same thing may not apply in all poisoning patients. These are the patient, if you know patient has taken unknown poisoning, they need sometimes longer efforts to resuscitate. They need longer time to revive. Maybe sometime you end up giving them hour of CPR and salvaging them. And it is still worth trying, because poisoning is one condition where you need at least to give them 4 times of the half-life of poison to give them a chance to survive. Suppose some of the poison may have half-life of 72 hours. So at least whatever is the condition, they may need another 42 hours multiplied by 4 times to give them chance to survive. And a lot of patients, you won't believe that we had saved a patient who remained comatose of a snake bite for 8 days, almost brain dead, and just on suspicion somebody said that it may be snake bite because we are not getting any diagnosis. And 8th day we gave anti-snake venom, and 9th day boy woke up. So like for poisoning, miracles happen. And poisoning is one condition where if you target that, because most of the patients are young, where if you target, you can save almost 100% of your patient. Almost, I'm not saying. There are certain poison we don't get in time, like sulfas, it goes in multi-organ dysfunction. Despite we have all the efforts, we lose patient, but still poisoning and trauma are two conditions, because most of the patients are young. If they come to an appropriate physiological reserve, you can save most of the patient, and that's the reason you need to know a little bit about it. But one thing, the typical classical ACLS approach, that 5 minute, 10 minute CPR you do, and all the protocol of, if you try to apply ACLS protocol for poisoning, you end up sometime doing wrong. So particularly for managing arrhythmias, particularly for managing the bradycardia, you may need something for cardiac patient, but when it's poisoning, you need something different protocol. So with this background, what is our first priority? If you get an unknown poisoning patient, the first thing you want to ensure that your patient is room congested or weather bad, so many people coughing, or I am talking very bad? None? Okay, fair enough. So first priority is we need to know, is patient alive? And even if patient is brain dead, if somebody has brought them, if you try to revive them, if you can revive their heart, don't declare. Because poisoning is one condition, as I said, that up to 4 times in heart life, you cannot say anything certainty. So do not apply same protocol which applies for the hypoxic brain damage to cardiac arrest. So make sure a patient is alive. If it's not alive, you can still take a chance to do the CPR. And nowadays, you have eCPR, ECMO CPR, particularly in a patient who are near arrest or arresting, not able to revive. ECMO CPR is one thing, one area where particularly for poisoning patients who are coming in severe shock is doing extremely well. So if affordability is not issue, money is not a problem, eCPR may be a good option to think. ABC is our main tenet. For anything we apply ABC. But where it is different, how it is different in applying ABC protocol, I will elaborate a little bit later. When you get a patient poisoning in emergency, because these patients are young, always be alert that your crowd may be hostile and sometimes you will become victim. To be very careful when you are dealing with these patients. Second thing about the safety of yours. There are certain poison when you are trying to open the cloth or trying to intubate, spillage may contaminate you or you may get poisoned, particularly if it is skin poison or mucous membrane poison. So be very careful when you are handling, particularly if it is an industry poison. There can be dye, there can be something in pocket, so you may get affected with that. So be very careful. But the key support is airway. If your patient is unresponsive, unconscious, you need to protect the airway. That is most important. What will be the one key thing? What most important thing when you are trying to protect the airway, you will keep in mind in this patient? Sorry? Okay. An unknown poisoning patient comes to you, unconscious, not responding to pain, maybe GCS less than 8. You have to protect the airway. What one thing you will keep in mind? The most important thing. Sorry? I can't hear anything. One person. Sorry? Can somebody say what's saying? Stomach. Full stomach. Okay? Okay? Sorry? Safety of? Okay. With time, I'll let you know. But none of you have answered what I wanted to say. After you have ascertained that the immediate concern has been taken care, you need to think that what are the measures which has to be fixed immediately to prevent further deterioration of the patient, and definitely as a rule you put wide bore cannula, preferably 2. You look for the vital. You look vital to see that the patient is alive. Also you look vitals to find out the probable cause of poison. So here when you are managing this patient, though as an intensivist our first approach is to manage the patient, but immediately simultaneously start thinking what can be probable poison, what can be probable toxin, and what can be probable antidote we can give early. So you have to think in that direction as well. So vitals, here you see heart rate, blood pressure, oxygen, respiratory rate, blood sugar, skin, temperature. When you see all these including GCS and pupil, when you see a record, simultaneously you try to rule out what? AC बंद कर दिया है क्या? Okay. So what you try to rule out? What you try to find out, except seeing that a patient is alive, when you see these vital signs, simultaneously you try to approach the toxidromes. Because all the toxidromes, which category of poison this patient will have the constellation of these signs. So when you see this sign and you try to put these signs at one place, simultaneously you approach probable cause of poison and try to find out which toxidrome patient may be having. So it's not one approach that you see vitals and your job done. No, you have to start thinking laterally also to find out the probable. Okay? Any question on this? Any thought, second thought? Okay. Then, as a rule, make it a note कि whenever you get a patient, particularly he has come with unconscious state, unresponsive state, always think that this patient can have a cervical spine trauma until unless ruled out. So when you are going to intubate this patient, in all unresponsive patients, despite they are having cervical injury or not, despite they are having history of trauma, because you may not know what has caused, what he has taken, where he has fallen, what kind of internal injury he has. Inline cervical spine injury stabilization is ruled. And that's what I wanted to hear in the previous. Then when you are going to secure the airway, always and always in all talks in unknown poisoning patient, inline cervical stabilization is the rule. So when you answer also in your exam, particularly unresponsive unknown poisoning patient, the moment you ask I will secure airway, other adjective should always be said with inline neck stabilization, and by doing that you have just avoided 5 more questions which can come to you from examiners. Okay? Are you agreeing to this, or do you have any disagreement on this? Anybody has second thought on this? Look, I am going little bit up slow because you people are not reacting. So I am not able to understand what I am talking. I am talking something wrong, or you are not able to understand and you know everything and I am just talking. So there is some problem. So there is no connect between me and you. So I mean, disconnected audience with a speaker is something very, very dangerous situation for me. So I am not able to judge what is happening really. Sorry? You are not tired. That's why I am little bit slow, and I'm just trying to diffuse your lactate level. That's why I'm little bit slow and trying to put, I mean, whatever best way I can do, I'm trying to put it up. So I understand 5th day of the conference, sitting and listening such a boring lectures is not easy, I mean, task to achieve. So I can understand that it's a very, very difficult thing to do that, and people are doing good job for that. Excellent. Another important thing, you have to have a checklist. None of us can remember everything. You have to have a checklist to have a organized, well-structured history. Because if you do not take history, after you have stabilized the patient, you will miss the diagnosis. And some of the important thing is that who are the first person who has seen the patient, because he will give you the most vital information. When was this patient seen alive or walking first time, that will give you a lot of information. Condition, his surrounding, his sleeping place, if he has any empty bottles, he has any drug wrapper. Once he was found, what had happened, was he brought straight, he arrested, who has brought him here, any medication history, is a drug history there, his age, his travel history, all these things. Because most of the time when I start taking history, we do not ask until unless we have a checklist. So until unless you become proficient, you start practicing this, you will not remember this. I also don't remember. So we keep nowadays the time of checklist, what you have forgot. So you will not remember at one shot everything. You just ask whatever remember and go and check your checklist, what you have missed if you are not able to diagnose. If you are able to diagnose, fair enough. But if you miss that thing, it's only history which will give you a clue to find out the cause. I'm not going to elaborate each point, but asking each and every point, like suppose geographical area, why I'm asking. If somebody is coming from like I tell you, I had a patient who came to me who has gone to sleep just, and in morning he just got up with only breathlessness, sudden onset breathlessness. He got up. There's no complaint. Young patient. He has brought whatever workout we did, we could not find out any cause, any poison up to 24 hours. We had to intubate the patient, put on ventilator. He was highly irritable with all the parameters normal. Except he started developing thrombocytopenia and coagulopathy. So only clue we got that he slept on ground in closed room on first floor. The only clue he was sleeping on ground, nothing else. And based on that we suspected it may be what can be? A snake bite. And just based on suspicion of this, what he went to that, except that he was alone in room and he was found unresponsive. And giving anti-snake venom has brought him back. So just a small history may do wonder for your patient, and you may save some of the most difficult patients you may be thinking of. As I say that in critical care, treatment and diagnosis go hand by hand. You start treatment, you secure your way, you ABCD, E, F, whatever you do. But simultaneously, once you secure, look for the diagnosis, important component history, physical examination, looking for toxidrome, recognition and diagnostic test. This toxidrome, all of you must have, whosoever is reading must have read. The problem with the toxidrome is that when it really comes to diagnose, when you start practice, it's very difficult to remember everything. So at least 4 toxidrome, 4 or 5 toxidrome you can always remember. You have to just go back to your 4th semester of pharmacology classes and just remember what sympathetic nervous system does to your body. And what is the most common sympathomimetic effect? Tachycardia, hypertension, tachypnea. What will happen to pupil? Sorry? Dilated. And if it is too much, patient will be irritable. I have not seen anything, just whatever is written here it will be same. So just you have to look for the 3 signs. What is happened to cardiovascular system, what is happened to pupil, what is happened to CNS, and based on these signs, because mainly sympathetic and parasympathetic system affect this. Later on gut. They affect everything, but these are the things which are vital, and these are the things where patient survival depends. At the end of the day, patient survival depends upon your sensorium or consciousness level and cardiovascular stability. If these 2 things are fine, rest of the things you can handle very well. So, what is the most common drug would be? It will be common poison, which will be sympathomimetic. Sorry? Cocaine, okay. Anything more common? Sorry? Yes, it's very common. Yeah. Same thing, let us know about the most common poisoning, organophosphorus. Which category it is? Organophosphorus. Which category it is? Sorry? Parasympathomimetic. What will it cause? Parasympathetic. What will happen to heart? What will happen to pupil? What will happen to brain? Not very clear, but it varies with the stage. It can be right from irritability to convulsion, depending upon the poison, if it has crossed the blood-brain barrier. One thing is, because parasympathetic system affects the lung also, what will happen to lungs? Secretion and bronchospasm. Just see, I did not see the slide. I just told you have to categorize your toxidrome in these 4 criteria, and you are yourself answering. If you try to mug it up, probably you will not be able to remember. But if you try to apply your brain, this will stay for you, even if you forget everything. If you just have to apply, okay, if it is parasympathetic, if it is sympathetic or sympathetic. Okay? The 4th category of the poison are opiates, because they work on different. Ultimately, toxidromes are based on your receptor level. Opiates are a different receptor. What will opiates call family? CNS depression. So if somebody comes, same way benzodiazepines. So not necessarily you remember the toxidrome as such, but in your MCQ, maybe examiner may not ask you in exam, but in the MCQ or in your write-up, sometime you may get a question of toxidrome. So common toxidrome you need to remember. If you remember basic physiology, pharmacology, even if you don't remember anything, you will answer almost 90% correct. It's okay? Because after lactate level बहुत ज़्यादा था, I tried to find out some other way where you yourself say what it is rather than I speak about. Fine? Fair enough? Okay. Same thing has been charted, no point in going in detail. Now, as I said, there are, when you are looking for the vital signs, there is a long list that which poison will cause tachypnea, which poison will cause pulmonary edema, which poison, but certain thing you need to remember definitely. Like suppose somebody comes to you with hyperventilation, you suspect it is sympathomimetic, amphetamine is the commonest thing. Suppose somebody comes to you with only pulmonary edema, severe pulmonary edema. The what will be the most common cause to cause severe pulmonary edema? The drug which can affect alveolar endothelial can cause that dysfunction, affect those receptors. And which is the commonest drug used to suppress the cough? Why do you use that? Because it affects the receptor. So, when you take in high dose, those receptors those connection get breached up and you can have non-cardiogenic massive pulmonary edema. So much so, and another mistake you can give is by giving Lasix and doing more harm to this patient. The non-cardiogenic, non-flow rate overload, severe pulmonary edema, opioid is one of the most commonest drug to cause. Have you ever? Severe respiratory depression, your glottis gets closed, intrathoracic pressure increase up, while here it is suppressing your cough reflexes, not opening, and then it leads to, that's what the mechanism is about. What about the bradycardia, CNS depression? What about the toxin which can cause altered mental sensation? The one toxin which I want you to remember is nowadays. Initially, we used to see a lot of opioid poison which used to come with the neuromuscular dysfunction and paralysis. Nowadays, because of the change in constituent and the constituent we are more of the tertiary compound, they crosses blood-brain barrier. So you get burst kind of opioid poison with primarily CNS dysfunction, becomes with the irritability, convulsion, bradycardia and cardiac arrest. So if you are not very careful about it, and if you are not using benzodiazepine as an antidote and not sedating them well, many times they wake up, through convulsion and cardiac arrest, simultaneously die. And simultaneously, if you use antiepileptic, it further worsens the situation. Because antiepileptic, any of the antiepileptic in poison-induced convulsion, a poison-induced problem, maybe antiarrhythmic or anticonvulsive, they further propagate the problem. You can go through the mechanism how it happens, but you need to have that information that any of the antiepileptic, any of the antiarrhythmic are propagative to those problems and should be avoided. So you have to be very, very careful. So even if a patient is irritable, sedated, he is under medicine, but they need high dose of benzodiazepine to control that convulsion and keep them calm. Are you okay with that statement, or you have any contrast in your mind? If आप कन्वर्जन आना तो एंटी कन्वर्जन क्यों नहीं देना? एरिथमिया है तो कार्डोन दूंगा, क्या प्रॉब्लम है आपको? Anybody? No? Everybody agrees with that? I mean, this is the only time you can ask me. You will not be able to ask across the table. So if you have any question, please free to ask. Everybody agrees to that. Fair enough. You need to have, time is getting over, I need to quickly run off this. One more thing about you need to remember very quickly, anion gap. Whenever you are not sure about what toxin it is, look for the anion gap. And if you remember the cat mud piles, you can almost rule out find out all the possible. But the most important thing is if you find somebody with acidosis and decrease in anion gap, always try to think about the heavy metal poisoning, particularly lithium. Lithium is one thing which is very common, very narrow safety margin, very toxic drug, and is therapeutic. So particularly if you are looking for the lithium, somebody is on, you have to look for the ABG with decrease in iron gap, and that's the only condition. So you need to remember this for your question also, and for saving some of the important patients. So 3 gaps, anion gap, osmolar gap, and oxygen saturation gap is the most important when you look for the unknown poisoning, because anion gap will lead to a different set of diagnosis. If it is increase, decrease. If it is osmolar gap, you are very quickly able to find out sometimes some of the ethylene glycol or ethanol or even glycerol, some of the rarest propylene glycol which you can normally not think. But sometimes these patients who get exposure to industry because of some of the medicine, you can find out the problem. Industrial exposure of carbon monoxide, sulfhemoglobin, methylene dye, you find a increased oxygen. What is? Are you able to understand what osmolar gap is? What saturation gap is? Everybody knows this. Anybody wants to me to explain? But these are the important tests. The only thing is when you are looking for osmolar gap, ask your lab that measure the osmolarity by freezing point separation, not by conventional method. So you calculate osmolarity and you measure by freezing point. And if the difference is between more than 5 milliosmol, then probably you are dealing with one of these things, particularly one of the rarest thing you can find out. And same thing about oxygen saturation gap. You look for the SpO2 and you look SaO2, and if there is not matching with that, and that gap is more than 5%, then probably you are dealing with very classically, particularly if you have carbon monoxide, cyanide, sulfhemoglobin, your saturation fixed up to what level? 85, 84 it fixed up. While same thing you monitor as a difference. So very clearly you can quickly diagnose and further manage. So for DK, you have to look for the formula of cat-mud piles. It's very commonly known where everything comes in that mnemonic. I need to remember it. I cannot elaborate that. Certain toxin can cause rhabdomyolysis, hepatotoxicity, methemoglobinemia. Need to remember, and it's an elaborative line. You need to measure certain toxins, particularly those toxins who are stored and can get released repeatedly and has narrow therapeutic margin. Particularly if it's like aspirin or antiepileptic or theophylline, these are drugs which are they are very toxic and they need to be monitored frequently. There are certain poisons which you need to monitor in certain time. After that, if you monitor, there is no value because they have done enough damage. So there is no chance of repeat relief, but the kind of damage they can do, it can be enough to kill the patient. So particularly the acetaminophen, only thing is that when you are looking for the paracetamol or paracetamol poisoning, within 24 hours only that pneumogram has value. After 24 hours, even if you do paracetamol and whatever level comes, already liver dysfunction has done, there is no point in repeating it. It can be level, can be any, but then you have to manage the liver dysfunction and its side effect. So within 24 hours, it helps you in finding out how much, but still, we use a lot of N-acetylcysteine whatever time patient comes. You need to remember potassium when you are dealing with deoxyribotoxicity, beta blocker, you are dealing with hypokalemia. You need hypocalcemia, particularly for ethylene glycol, if you see. It is so severe that it can cause tetany and convulsion to the patient. Worst respiratory spasm, where you may find difficult to intubate the patient. Sugar may be very high, particularly beta agonist and calcium channel blockers. Now, so what you do? You take history, you go for the non-conventional approach, you try to find an antidote and look for the heroic measure like eCPR. Very quickly, if you have to summarize everything except history, you look for the three things to approach. It's Brady or Techie, try to group your patient. What happened to eyes is nystagmus, miosis or mydriasis, you group in the patient. And then what is the sensorium level? Is depressed, agitated or confused? Accordingly you group the patient. There are certain laboratory evaluation. If it is unknown, it should go in one go. No need to repeat and then. Once you have stabilized, apart from your routine test, urine toxicology, whatever toxicology your lab does, 5, 6, 8, 10, 12 medicines, send all. Don't try to apply your brains. Many a time we do not know and very funny things come out. So just ask the lab how many toxin you do out of this. Look for the, if you are not very sure, at least anion gap. If there is any problem, if you see a monitor, oxygen gap, and if you find anything where you need to look for the, you are not sure, and industry exposure, look also for osmolar gap. Just seeing all these three gaps further can narrow down your differential diagnosis. General management, very quickly, if patient is unconscious, still coma cocktail has a value. If you can monitor sugar is fine, if it's normal, but since you will give thiamine, you will need dextrose to utilize it. Naloxone in all unconscious patient until unless rule out, particularly if it is antidote and have to. We have a tendency to do gastric emptying emesis. Just avoid a caution. If a patient has come to you after 2 hours, in most of the poison it doesn't have any value. And if you at all want to do, first you protect the airway and then do gastric emesis. Do not do this thing in unprotected airway, in patient having alkali acid poisoning, in petroleum product, kerosene overdose, and if poisoning is more than 2 hours. Activated charcoal we intend to give. The most important thing, it has to be given with lactulose or any other catharesis. One dose is definitely, but giving it is a very hard task. You have to give almost 50 to 60 gram of activated charcoal. You know what activated charcoal is? Anybody knows? A price of 100 rupees, if anybody can tell what activated charcoal is. Cash. 500 rupees. So it is a question for you also. Go and read and you will be surprised what activated charcoal is. How it is made activated charcoal. Anybody wants to try more or shall I go ahead? नहीं गूगल करके नहीं, चीटिंग नहीं, डोंट डू चीटिंग यार. आजकल हर आदमी कुछ नहीं कर रहा है तो एक चीटिंग करना सीख गया है जो सबसे आसान है. डोंट डू दैट यार. वी एक्सपेक्ट सम प्रोफेशनल ऑनेस्टी फ्रॉम डॉक्टर्स. हाल तो हमारी कंडीशन काफी खराब होती जा रही है, बट स्टिल वी एक्सपेक्ट सम ऑनेस्टी फ्रॉम अस यार. ओके, हाँ, मल्टीपल डोज is helpful in anti-epileptic, beta blocker, quinidine, theophylline, salicylate and TCA. You need to give 2 or 3 doses in succession of 12 to 24 hours. But the only thing is give it laxative, otherwise it can obstruct your intestine and you have to operate it. Don't use charcoal in alcohol, acid alkali, OP, hydrocortisone, lithium and iron. It can further worsen the things. Okay? We need to eliminate. Urine alkalization is must. You have to target a pH of 7.5 and urine pH of at least above 6, particularly if it is salicylate, phenobarbital and TCA. Hemodialysis is एक मिनट शालिन मैं एक लेक्चर में 10 मिनट कॉल करता हूँ. Sorry. HD you have to do, particularly if it is methanol. Don't wait. If there is acidosis and patient has come with methanol poisoning, before it does blindness, before it causes sinus dysfunction, before his patient dialyze it and remove, and dialysis will be also very prolonged. It may not be 4 hours, 6 hours, sometimes this patient long dialysis. Correct acidosis, try to remove it. You have to do antidote. Hemoperfusion is a cartridge where it is coated with charcoal. Then you pass the blood and it absorbs the toxin, and its theophylline anti-epileptics are the useful. Hemofiltration, particularly if you have come with desferrexine or DG, iron overdose and digoxin overdose. So these things you need to remember. All poison patients, even they agree forcefully or willingly, they need to be observed in ICU at least for the half-life of the medicine, whatever they have taken. You never know when can unpredictable thing can happen. Although I am crossing, but these 3 slides I want to discuss and then I want to stop. I will not go for a specific poison. Airway. Except manual stabilization, which is the must for this patient, 2 issues you need to remember. Whenever this patient comes to you unconscious stage, always remember they can have hypoglycemia. Check for sugar, and if you don't have facility, give at least 25% dextrose. Second thing about the narcotics overdose. And you must try to give naloxone as is comocotil, but never give flumazenil, because the moment you give flumazenil at the end, suspecting that it can be benzodiazepine, even there is a history of benzodiazepine, it can cause worst convulsion of withdrawal and the patient can have further brain damage. So we strongly deny. If it is benzodiazepine, you know, overdose, it has got, what is the good thing about benzodiazepine? Very high margin of safety. Even if a patient has given 1800, 200, 500 tablet, it's not going to kill that patient, at least benzodiazepine. He will sleep for 3, 4, 5 days. Just put down the tube, ventilate him safely. But don't try to give any of these things. Whenever you are going to try for rapid sequence induction and intubation, preferably use rocuronium because some of the medication, as giving succinylline, some of the toxin can interact and can worsen the patient. So preferably shortest acting drug is rocuronium, which should be used for paralyzing. If your patient comes with stridor, never ever give any sedation and paralysis. Try always awake intubation. If you fail, you can go for mini track, but never. For any reason, if a patient is having a stridor, for any reason, and if you sedate the patient, for sure you are going to kill the patient. So first try awake intubation. If it fails, look for mini track and then go. Breathing. बी वेरी सर जी मैं 2 स्लाइड हैं खत्म कर रहा हूं जस्ट तो ब्रीदिंग बी वेरी प्रिसाइज बिकॉज नॉट ओनली ऑक्सीजन गैप most of the time when it is salicylate and aspirin overdose, patient hyperventilate, and the moment you intubate the patient, you induce respiratory acidosis. So if you are intubating these type of patients, take a precaution of giving 2 ampulla of soda bicarb before that, and try to match after intubation that, forget about the lung protective and all the ventilation here right now. Try to ventilate that much as patient was ventilating. Otherwise, the moment you induce intubation induced acidosis, this patient may arrest immediately. So give soda bicarb to protect yourself, particularly if you are dealing with salicylate and aspirin overdose. And then try to hyperventilate the way, because this patient has to blow out lot of CO2, and they hyperventilate, they ventilate with around 15-20 liter of the minute ventilation. So try to match that. When to avoid oxygen? Somebody said right. So paraquat is one poison, one toxin. If you give oxygen, it will cause more free oxygen induced radical injury and more lung injury. So as much as possible, if patient breathing is comfortable, even saturation is 85, try to avoid giving oxygen to paraquat. So I'm not here to tell you about what breathing, but something basic information I wanted to give. Same thing about the shock in poisoning patient. Managing shock is as usual noradrenaline, but where it is different, don't try to give too much of fluid if it is not. If it is bradycardia and hypotension, try to find out the cause, and some of the common causes I have mentioned here. If those things are there, try to give antidose. In bradycardia, never try to give until it is a life threatening, you can manage with that. Never try to push too much of atropine in this patient except OP. Monomorphic white complex tachycardia, sometimes some of the poison causes. What is the most common poison which will cause monomorphic? Sorry? TCA type, perfect. So what should you do? Amiodarone? Lignocaine? No. If patient is irritable, keep them calm and use antidote, particularly soda bicarb. And if it is polymorphic BT, particularly due to drug or toxin, so here you use isoplanine, because it's a bradycardia which prolongs QT syndrome, and that's why they develop polymorphic BT. So you increase the rate by giving isoplanine or by overdrying patient. Never try to treat polymorphic or other thing. The most important antidote is magnesium sulfate 2 gram. But never try to give amiodarone or any of these drugs to this patient. Immediately they will arrest. And if it is narrow complex tachycardia with hypertension, benzodiazepine is the drug of choice. And then phentermine, because you need to control both alpha and beta 1 blocker. Don't give either alpha blocker, don't give either beta blocker. You need to control both. Disability. I have already talked about coma cocktail. It's must. Naloxone I have spoken, don't give. What will you do for seizures? If any of your patient comes to you with convulsion and throws unknown poisoning and throws seizures. Phenytoin 1.5 gram. Levipil. What will you do? So same mechanism applies here. The way you are treating arrhythmia, electrical instability, don't use anti-epileptic. Rather than use you, calm down the patient, and best drug here will be benzodiazepines, or try to find out the cause. But never try to give anti-epileptic in these class of paper. Whatever dose of benzodiazepine you have to give, you give, but don't give anti-epileptic. And another problem with the phenytoin is the propylene glycol component further worsens the seizures in these patients. You can use propofol, and sometime if patient has taken INH in high dose, then pyridoxine, because some of the patients who are on AKT, INH is one of the drugs which can cause worst neurological dysfunction, and pyridoxine, you have to give around 5 gram of the pyridoxine in high dose. You have to. I'm not going to individual poison. I have already taken too much of time. So thank you for your attention. I hope in your high lactate level, I could little bit penetrate whatever I could do. Thank you.
Thank you, sir.